Well, good day to you. This is Dr. Nguyen. I'm one of the presenters and representing the team here of Eye Specialists of Georgia. I have myself as Dr. Dao Nguyen, Dr. Ahmed Nasser, our colleague Dr. Bo Young King, and we are doing a presentation today. I present to you Diabetic Retinopathy, Insights and Perspectives. So just a little bit about the presenters. Like I said, myself, Dr. Nguyen, I'm an optometrist, along with Dr. King, who's also my fellow optometrist. And then Dr. Nasser is our ophthalmologist. We're a 3-doctor setting at Eye Specialists of Georgia. Dr. Nasser has been in practice since 2004. I have been in practice since 2008, and Dr. King has been in practice since 2002. Dr. Nasser here at Eye Specialists of Georgia, we specialize in cataract surgery along with anterior and posterior segment procedural treatments of the eye. And he also does selective trabeculectomy and other treatments of glaucoma. Dr. Nguyen and Dr. King here, we're both specializing in diagnosis and treatment of anterior and posterior segments of the eye, as well as the contact lens fitting for all ages. Our practice, as I stated earlier, we are located in a densely populated urban area of Atlanta where diabetes and glaucoma are the primary ocular diseases that we see day in and day out. But that's just the gist of our clinic. But if you want to learn more about our practice, our website is eyespecialistsofgeorgia.com. Okay, just before we start, all 3 doctors do not have any financial relationships to disclose, and we will not be discussing any label use, off-label use, or investigational use in our presentation. Okay, first of all, diabetes mellitus, as you know, is actually a very broad topic. You probably already know a lot about mechanism and everything behind diabetes, but for the purpose of our presentation today, we will focus on diabetic retinopathy. But just a little background on diabetes. As you know, it's probably one of the most challenges to healthcare worldwide, and there's an increase in the prevalence appear in the developing countries. Statistically, it affects about 28 million people in Europe, about 19 million people in North America, and about 138 million people in Asia. And there's a small population of about 1 million in Australia. And diabetes mellitus is the leading cause of vision loss and blindness in people between the age of 25 to 74 years of age. That is the NIH studies. The prevalence of blindness due to diabetic retinopathy in Western community is estimated about 2 out of 100,000 people. So what are the some of the causes of diabetes? So in other words, what trigger this disease? There are many causes, but the 3 primary causes of diabetes are the changes in the diet with a higher fat intake. Another cause is the sedentary lifestyle changes. And then lastly, decrease in physical activity. So in other words, the less active you are, the greater you're at risk for type 2 diabetes. So physical activity helps you control your weight, uses up glucose as energy, and basically makes your cells more sensitive to insulin. So what are the risk factors of diabetes? We narrowed it down to 3. The first one is the age. So the risks of diabetes increase as you get older, especially after the age of 45. That's probably because you tend to exercise less and lose mass, muscle mass, and gain weight as you age. The second thing is the family. The risk of type 2 diabetes increases if your parent or sibling has diabetes. And the last thing is the ethnicity. So we see here in our clinic, African American has a very high prevalence of diabetes. And then we also see in other races like Native American or Asian American, as well as Hispanic and Pacific Islanders. Okay, so now let's look into some of the diabetes, how it affects the eye, and some of the anatomical terms how that goes into effect. So I have here the anatomy of the eye, and so I want to point out to some of the structures how diabetes can affect the eye. The first thing is the cornea. There's a lot of complications when you get diabetes, how it causes there are a lot of conditions that we detect with the cornea, like dry eyes or other cases of corneal erosions or epithelial defects from the cornea. With glaucoma, there's an elevated intraocular pressure, which often is associated with patients with diabetes. And also the iris neovascularization, which is probably one of the most serious consequences of diabetes. when they're not controlled. And then we also have cataracts. So we'll go into the mechanism of how that causes diabetes or costs stemming from diabetes as we go further into this lecture. But also the neuropathy, specifically the optic neuropathy. And then lastly is the diabetic retinopathy, which is one of the most common and potentially most blinding of these complications. Okay, and then the next case we want to give you is an overview of diabetic retinopathy. And as I stated earlier, between the age of 25 and 74, it's probably one of the leading causes of the new blindness in this age group. Like I said, there's about approximately 700,000 people in the U.S. with proliferative diabetic retinopathy, which is the most severe case. And then there's an annual incidence of about 65,000 of these. And also the prevalence of people with diabetes above the age of 40 is going to increase about 30% in the next decade. And then the last thing is, as much a study as we have out there, the exact mechanism that was caused by diabetic retinopathy is still unclear. But however, there are some theories that have postulated to explain the typical cause and history of the disease. So we're hoping, in the future, as the more study and the more progress we make in medicine, we're going to have a better understanding of the mechanism of this. So I want to show you just a picture of what the normal vision looks like from a patient's perspective, as opposed to someone who has diabetic retinopathy. And so as you can see here, the normal vision is, just a clear case here. And then with the vision with people who have diabetic retinopathy, it just appears to be blurry and distorted, and a lot of times they'll see like a yellowish or faded blemish through their vision, and also an increase in the glare, the amount of glare that they see. And so just a basic on what they're actually seeing is just the initial, if you're first having diabetes and then you're going to your doctor and they're just detecting the initial stages of diabetic retinopathy, most of these patients are asymptomatic. But in the more advanced cases of the disease, you're going to see a whole lot of floaters. They're going to be coming with progression on the visual acuity, as well as the or progression on the visual acuity loss, as well as the distorted vision. So how do we screen for these diabetic retinopathy cases? So from a clinician's point of view, we screen for these patients when they're coming in for their annual eye exam, or a lot of times we'll get cases referred in from the internal medicine doctors. And so the first thing we measure, obviously, is their visual acuity. And so particularly noting the changes in their vision in the past 90 days, for example. And then the second thing we look through is the slit lamp. We're detecting to see if there's any kind of iris changes, patterns of neovascularization. And also the third thing we check for is the crystalline lens. So naturally you're having a clear lens, but as you age, that lens gets cloudy. But with the patients with diabetic retinopathy, that amount of clarity gets opaque or gets distorted, or gets yellowish a little sooner than the ones who have normal vision. And then we also do a fundus, dilated fundus look in the back of their eyes to check for any changes in the retina. So just to give you a picture of what the clinician's point of view is when we look at the fundus of the patients with diabetes and without, with diabetic retinopathy, and the patients who has normal fundus. So to my left here, you'll see a normal fundus, which is clear. You have normal retinal vasculature there, as well as a normal nerve tissue going into the nerve. And then onto the right here, you see a patient with diabetic retinopathy, which you see all kinds of activities per se in this slide here. And we are going to go through with these changes in a few minutes as we go through into these slides. So what are the signs or what are some symptoms of patients who have diabetic retinopathy? Well, these are some of the clinical signs that we're looking for. I'm going to kind of briefly go over this with you, but basically this is kind of the main points that we're looking for when we look into their retina. The first thing we look for is the microaneurysm. This is actually pretty early in the signs of diabetic retinopathy. Basically, it's just a capillary wall that just outpouches due to the parasite loss. So they usually appear to be pretty small, and they have red dots in the superficial retinal layers. And the second thing, or normally we look for when we dilate, is any kind of dot and blot hemorrhages. So basically, the microaneurysm, extension of that, and that it ruptures into the deeper layers of the retina, otherwise known as the inner, nuclear, and outer plexiform layers. We'll also be looking for flame-shaped hemorrhages. They're basically splinter hemorrhages, so it's on the superficial nerve fiber layer. And also for the retina, we look for any kind of hard exudates or any kind of retinal edema, which is basically a breakdown of the blood retinal barrier layer. And then we're also looking for cotton wool spots. They look like white patches, but it's just basically a nerve fiber infarctions from the occlusions of the pre-capillary arterioles. Other things we look for, mainly we're looking for macular edema. That's what I normally, first thing I look for. After I look for any kind of microaneurysms or any kind of hemorrhages, because if there's any changes in their vision, that's the first thing you look for, any kind of macular edema. Other things you look for are like ARMA, what's called intraretinal microvasculature. Okay. All right, so just all those terms to be put into pictures, you can see here we have a normal retina to your left, and then we also have the patient with diabetic retinopathy. So some of the things I described earlier to you there. So these are the cotton wool spots that you're seeing here, and then the microaneurysm as well as the exudates and edema, which usually appears around here, the macula. And then you're going to see here the optic nerve in a patient with diabetic retinopathy compared to a normal patient over here. Everything's clear, but you're going to see more attenuation. You're going to see more neovasculature, just basic new blood vessels growing around the optic nerve. Okay. There are 4 stages of diabetic retinopathy. Of course, there are preliminary stages that we're also considering, but according to the National Eye Institute, we break it down to 4 stages. So we call them the mild non-proliferative diabetic retinopathy case, the first one, and then it goes to the moderate non-proliferative, and then severe non-proliferative, and then lastly is the proliferative retinopathy. So in terms of categorizing these, there are certain things that we look for. Obviously, you know, the first stage is it appears to be normal. You don't see any abnormalities. But when it comes to the first case, we see the mild non-proliferative. The main thing that you're looking for in these retina are the microaneurysms. And they appear to be clear for the most part, except for some of the microaneurysms that appear all over the fundus. And then we get to the next severity case, which is the moderate non-proliferative. And this is just a more microaneurysm, but then they are less severe than non-proliferative. So when you get to severe non-proliferative diabetic retinopathy, they'll have at least all the above, as well as the definite venous beating in 2 or 3 more quadrants. And what's prominent is the intraretinal microvascular abnormalities. These are basically what's called ARMA, and they're coming in from different quadrants on the fundus. And then lastly, which is the severe case, which is the proliferative diabetic retinopathy. And this is what you really don't want to see, because when you get to this stage, they're going to have all kinds of stuff in addition to neovascularization, which is new blood vessels growing, and then they're also going to be vitreous and pre-retinal hemorrhages. So at this stage, which Dr. King will go in on later as far as how we treat, but when they get to this stage, their vision is actually pretty severely reduced. Just another diagram here showing you the difference between the non-proliferative on your left here as opposed to the proliferative on your right. So as I stated earlier, on the non-proliferative case, you don't have what's called neovascularization, as opposed to the right here, you have the neovascularization, otherwise known as the growth of the abnormal blood vessels, otherwise known as neovascularization. So when they get to these two stages here, that's when you really gonna be more concerned about their vision. You're gonna see a whole lot of activities in the retina. And just another basic diagram that go through the 4 stages of diabetic retinopathy again. So it goes from the normal, and then we call them background or pre, and then non-proliferative, and then goes on to severe, and then the proliferative case, and then fibrovascular membranes. That's really going to be a very pale looking retina. You have, again, all kinds of activities in the back there. So just a basic, some of the things that we use to diagnose these patients. Imaging, when you are using for diabetic retinopathy, we use in our office what's called fluorescein angiography, and just basically an injection dye into their vein or to the vessels, and then we're looking for any kind of hypofluorescein lesions in the early stages. And then we're also looking for any kind of leakage that shows up in the fundus when we take these pictures. And also in our office we have the OCT, which is the optical coherence tomography. And this is actually a pretty good test to detect any kind of swelling or any kind of edema that goes on around the macula. And then lastly, we also use the B-scan ultrasonography to detect and see if there's any kind of hidden things that we cannot see, especially if there's a cataract that is in place due to the diabetic retinopathy. So these 3 scans, we primarily use the first 2 in the early stages of diabetic retinopathy. So, and Dr. Nasser and Dr. King will go through with these scans and kind of tell you more of how we use these tools in depth in our treatments and pathology of the cases here. So I will turn to Dr. King right now, and she will take you guys to the next section here. We're talking about the pathophysiology.
Hi, my name is Dr. Bo-Young King. I'm going to be presenting to you the next set of slides. Basically, I will be talking about pathophysiology, etiology, and epidemiology of diabetic retinopathy. So pathophysiology, it's pretty cut and dry. It's your chemistry courses that you probably took in med school. The exact pathophysiology of diabetes is unclear, but here are some of the theories that doctors and scientists have come up with. It's contributed by the growth hormone, platelets and blood viscosity, aldose reductase and vasoproliferative factors, macular edema, hypoxia, and neovascularization. And the next few slides, I will be talking detail about each of those theories. The growth hormone is a big role in playing in diabetic retinopathy. Back in the 1950s, they actually used to use pituitary ablation to treat diabetic retinopathy. That's clearly no longer used due to better options such as laser treatment. They have also, in the same line, linked hypothyroidism with diabetic retinopathy. Platelets and blood viscosity and diabetic retinopathy. So these are the following things that predisposes the patient to retinal ischemia, which leads to diabetic retinopathy. Increase in erythrocyte aggregation, decreased red blood cell deformability, increased platelet aggregation and adhesion, hence leading to sluggish circulation, endothelial damage, and finally, focal capillary occlusion. As you all know, diabetes causes abnormal glucose metabolism, and that's a result of the poor insulin levels. This leads to an increase in blood glucose, which leads to poorly functioning retinal capillaries. The elevated blood glucose levels shunt excess glucose into aldose reductase pathway. That pathway converts excess sugars into alcohol. This elevated levels of alcohol deregulates the primary function of the retinal capillaries, which leads to weakness and saccular outpouching of the capillary walls. The microaneurysms, as Dr. Nguyen spoke about earlier, are the earliest detectable signs of diabetic retinopathy. Capillary changes represent the microvessel level of diabetic retinopathy. Ruptured microaneurysms then lead to retinal hemes. Increased permeability of these vessels result in leakage of fluid and proteinous material which appears as retinal thickening and exudates. Here are some slides of aldose reductase and vasoproliferative factors. The slide on the left is a fundus photograph of early diabetic retinopathy, and it shows, it's a bit dark, but it shows a couple of microaneurysms. The slide to the right shows more background diabetic retinopathy, including blot hemes, which is the long arrow right over here, microaneurysms, the short arrow, and hard exudates, which is the arrowhead, and these are the white hard exudates. Macular edema is the most common cause of vision loss in patients with non-proliferative diabetic retinopathy, and that's one of the main things that we look for in clinic. The shunting of excess glucose leads to excess diacylglycerol, which leads to development of macular edema. Diacylglycerose activates protein kinase C, which affects retinal blood dynamics, which then leads to fluid leakage and retinal thickening. Clinical significant macular edema is defined as the following. Retinal thickening located 500 micromilliliters or less from the center of the foveal avascular zone, hard exudates with retinal thickening, or retinal thickening 1 disc area or larger in size located within 1 disc diameter of the foveal avascular zone. So here you can see from a fluorescein angiogram where the foveal dye leakage can be caused by macular edema. And this is, as we mentioned before, another way for us to diagnose macular edema with a fundus photograph of clinically significant macular edema. And that shows the retinal exudates within the fovea. Another pathophysiology of diabetic retinopathy is hypoxia. Diabetic retinopathy eventually progresses to closure of the retinal capillaries, which leads to hypoxia. Infarction of the nerve fiber layer leads to cotton wool spots. Then the retinal hypoxia will result in our body's compensatory mechanisms to provide enough oxygen to the ocular tissue. Venous caliber abnormalities appear as venous beating and dilation adjacent to the areas of capillary non-perfusion. New vessel growth, such as neovascularization, act as shunts through areas of non-perfusion. Neovascularization is from increased in retina ischemia, which triggers production of vasoproliferative factors that stimulate new vessel growth. It most commonly occurs at the borders of perfused and non-perfused retina along the vascular arcades and at the optic nerve. The new vessels break through and grow on surface of the retina into the posterior hyaloid space. By themselves, these new blood vessels don't cause blindness, but they are very fragile and highly permeable. They are disrupted easily by vitreous traction, which leads to hemorrhage into the vitreous. In later stages, these vessels may regress, leaving avascular fibrous tissue at the surface of the retina and the vitreous. Vitreal traction on these fibroglial connections can lead to tractional retinal detachments. This shows a slide of new vascular vessel formation on the surface of the retina, which we also describe as NVE, which is neovascularization elsewhere. The second slide shows the area of neovascularization that leaks on fluorescein angiogram. In this third slide, you can see the boat-shaped preretinal hemes associated with neovascularization elsewhere. And you can see the boat-shaped heme right here. A couple more slides about neovascularization. We just saw this slide 1 in the previous slide. The second slide shows a microvasc within the vitreous cavity. So that's the white sheathing that you see here. In the third slide, you can see extensive fibrovascular proliferations within and around the optic disc. Next, I'm going to talk a little bit about etiology. So basically, if you have diabetes for a longer period of time, the incidence of retinopathy increases. For type 1 diabetes, the incidence of diabetic retinopathy is a little bit higher than type 2 diabetes. In type 1 diabetes, the first 5 years, rarely any patients have any retinopathy. After 10 to 15 years, that increases to 25 to 50% having retinopathy. After 15 years, 75 to 95% of the patients have retinopathy. And after 30 years of type 1 diabetes, almost 100% of the patients have retinopathy. Proliferative diabetic retinopathy with neovascularization is rare in the first 10 years, and it increases to 14 to 17% by 15 years of diabetic retinopathy. For type 2 diabetes, you can get retinopathy after 11 to 13 years in 23%. 14 to 16 years, you can get 41% of non-proliferative diabetic retinopathy, and after 16 years, 60% of the patients have non-proliferative diabetic retinopathy. Another factor with diabetes is high blood pressure and hyperlipidemia. High blood pressure can complicate diabetes even further. The combination of hypertensive retinal vascular changes on top of diabetic retinopathy further compromises retinal blood flow. With high cholesterol, controlled high cholesterol levels can reduce further retinal vessel leakage and hard exudate formation. Pregnancy and retinopathy. About 10% of pregnant women with diabetes without any previous diabetic retinopathy develop non-proliferative diabetic retinopathy. 4% of pregnant women with pre-existing non-proliferative diabetic retinopathy progress to proliferative retinopathy. Of those who have had previous retinal laser procedures, retinopathy remains stable throughout pregnancy. Pregnant women with diabetic retinopathy showed longer duration of retinopathy along with higher blood pressures. Epidemiology. Dr. Nguyen touched on this briefly before. We have data that shows we have 16 million Americans that have diabetes. Out of the 16 million, half of those patients don't even know that they have diabetes. Out of the 8 million that do know that they have diabetes, only 4 million are getting adequate eye care. Diabetic retinopathy is now the leading cause of new blindness in ages 25 to 74 in America. 700,000 of Americans have proliferative diabetic retinopathy. 500,000 patients have CSME, which is clinically significant macular edema. Diabetes is responsible for 8,000 eyes becoming blind each year. Diabetes is responsible for 12% of blindness each year. And there is higher incidence in Native Americans, Hispanics, and African Americans. Next, I'm going to present Dr. Ahmed Nasser.
Thank you, Dr. King. I'm going to start off speaking on the management of diabetic retinopathy. As far as pharmacologic therapy goes, we can use triamcinolone, which is administered into the vitreous cavity. It's a corticosteroid used in treatment of diabetic macular edema, and it's been shown to reduce the edema. Second, we can use bevacizumab, and that's administered also intravitreally. It's a monoclonal antibody that can help reduce diabetic macular edema and neovascularization of the iris, disc, or retina. And then lastly, we can use ranibizumab, and that's also administered intravitreally, and that's a monoclonal antibody that can help reduce diabetic macular edema and neovascularization of the iris, disc, and retina. As far as glucose control, as Dr. King touched on, the Diabetes Control and Complications trial found that intensive glucose control in type 1 diabetics decreased the incidence and progression of diabetic retinopathy. So it's vital that we discuss with our patients the importance of blood sugar control. One may be able to extrapolate that the same principles apply to type 2 diabetics. Management through laser photocoagulation. This involves creating a coagulative response in the target tissue, in this case the retina, by directing a high-focused beam of light energy. In non-proliferative diabetic retinopathy, or NPDR, laser photocoagulation is indicated for clinically significant macular edema. In proliferative diabetic retinopathy, PRP, or pan-retinal photocoagulation, is used to apply laser burns over the entire retinal area, sparing the central macula, thus effectively reducing retinal oxygen demand. Also, in diabetic retinopathy, we're able to recommend vitrectomy for some patients. This procedure has been proven effective in proliferative diabetic retinopathy in removing long-standing, non-clearing vitreous hemorrhage, reducing that also in turn reduces posterior pole visualization, so that way patients can see out, and then the doctors also can evaluate the status of the retina. It's also been proven effective in tractional retinal detachment, as well as combined tractional retinal detachment and regumatogenous retinal detachments. In the past, cryotherapy was more of a mainstay, and that's indicated when dealing with an opaque media and one is unable to view the retina or do laser coagulation, photocoagulation, and one may use cryotherapy instead in cases of white or hypermature cataracts and dense vitreous hemorrhage. And this was used a lot more frequently before the anti-VEGF therapies became more prevalent. Prognosis. Prognostic factors that are favorable for reducing the risk of visual loss include circinate exudates of recent onset, well-defined leakage, and good perifoveal perfusion. Prognostic factors that are unfavorable for reducing the risk of visual loss include diffuse retinal edema with multiple leaks, lipid deposition in the fovea, macular ischemia, which is very hard to reverse, cystoid macular edema, preoperative vision of less than 2200, as well as hypertension. The treatment of diabetic retinopathy entails a tremendous cost, but it is only 1/8 of the Social Security payments for vision loss. The cost of reduced productivity and reduced quality of life far outweigh treatment costs. The early treatment for diabetic retinopathy study, or ETDRS, has found that laser surgery for macular edema reduces the risk of moderate vision loss from 30 to 15% over a 3-year period. The diabetic retinopathy study, or DRS, has found that adequate scatter laser pan photocoagulation, or PRP, reduces the risk of severe vision loss, less than 5 out of 200 vision, by more than 50%. As far as patient education is concerned, this is one of the most important aspects of diabetic retinopathy management. Informed patients are motivated to play an integral role in their own eye care. As I previously mentioned, excellent glucose control is beneficial in any stage of diabetic retinopathy. It delays the onset and slows progression of diabetic ophthalmic complications. For those with diabetic retinopathy, the following symptoms and/or health concerns must be addressed in the patient education program. Systemic problems such as hypertension, renal disease. Also, smoking may further compromise oxygen delivery to the retina. Therefore, all efforts should be made to reduce and preferably cease smoking. And lastly, vision symptoms. Visual changes, floaters, distortion, redness, and pain could be manifestations of disease progression and should be immediately reported to your eye care provider. Diabetes mellitus, and particularly diabetic retinopathy, are progressive conditions. Therefore, regular follow-up and medical care is crucial to timely detect and care for changes that may benefit from early treatment. For more information, please refer to the American Academy of Ophthalmology Diabetic Retinopathy Preferred Practice Patterns, updated this year in 2016. Here are some references that we used in preparing this presentation. Lastly, I'm going to go over some of the questions here that were posed to us in the past. The first question was, does general medical school training provide what providers need to do to be able to do an appropriate screen? And I would say that depends on the skills mastered by the individual provider. One must be very adept and comfortable using a direct ophthalmoscope, at least to be able to visualize changes associated with diabetic retinopathy. Other equipment that's present at most optometry and ophthalmology offices are slit lamps, as well as other aids to further evaluate the retina, such as 90-degree and 90 diopter and 20 diopter lenses, and an indirect ophthalmoscope. Following question was, can nurses or medical assistants be trained to screen with certain tools and equipment? It may be possible. However, I think there's current studies that are currently ongoing to develop or to determine whether that's an appropriate treatment. As far as an exam goes by a competent medical professional, such as an optometrist or ophthalmologist, I think that that's very preferable to slides that may miss disease, such as telehealth. As far as scans that we use here in the office, we use scanning machines, as we mentioned earlier in our talk, such as the ocular coherence tomography machine, fluorescein angiogram, and fundus cameras. The question was, can it replace a visit to the ophthalmologist? And in my opinion, I would say no. And the reason for that is, just as I mentioned previously, what if the person taking the pictures misses the area of disease? Is it an effective and appropriate tool to increase access? Sometimes it's more desirable than no treatment in remote locations where there's no provider, and the pictures can be sent to a provider to evaluate elsewhere, provided that the person, again, taking the pictures took the appropriate pictures of and was thorough enough to make sure that they didn't miss areas of retina, and the quality of the scans were good enough where they could be evaluated in stereoscopically, so areas of thickening could be seen. Following question was, can you suggest any nonprofit or organizational support for screenings for uninsured or underinsured patients? Nationally speaking, we have providers here in our clinic who do volunteer missions, medical missions, as well as volunteer locally, and some different options are the Good Samaritan Clinic, the Lions Club, the VSP mobile buses, as well as the BPSOS for the Vietnamese Community Clinic. As far as resources, tools, and templates, patient education handouts, videos, and websites, I would recommend that diabetic patients refer to, again, the American Academy of Ophthalmology, as well as our website, www.eyespecialistsofgeorgia, to view some videos on diabetic retinopathy as far as the progression of the disease, as well as recommended treatments for the disease. I'd like to thank you all for listening and participating with us for this webinar from Eye Specialists of Georgia. We hope that you guys have enjoyed the presentation and that it was informative. If you have any questions, please feel free to contact Dr. Nguyen, Dr. King, or myself, Dr. Nasser, and we'd be happy to answer your questions. And we wish you all a wonderful afternoon. Thank you.